Ladies and gentlemen, dear Chairman Ali, thank you again for inviting me to have this talk at this nice conference in Cairo. So I would like to talk about cervical disc degenerative disease, and we have a big controversy. Should we go for arthroplasty or should we go for fusion? We heard about this topic a lot in the morning. So if you have a look to the anterior decompression and fusion surgery, it was, and I think it still is the golden standard because we have good clinical results, and using the technique we have not we have no relevant contraindication for this kind of procedure. The rationale why we think about disc arthroplasty is that we know that we have a little bit of problem if you fuse a segment, that the pressure in the adjacent segment will increase. We have the problem that we have an adjacent segment degeneration within 5 years, and there was a study from Goffin from 1995 that he told there are 92% of the patients they have an adjacent segment problem after fusion. And furthermore, from newer studies, we know that we have in the 10 years follow-up after fusion, around 1 out of 4 patients has a problem with symptomatic adjacent segment degeneration, and 2/3 of these patients with symptomatic ASD, they need an additional revision or additional surgery in the adjacent segment. That's why the industry has the idea to give us some other tools to overcome these issues, and they put the disc prosthesis on the market. And the industry promises that we have a preservation of our mobility. They will have reduced ASD rate if you use these kind of prostheses, and of course the surgery will tell you, the industry will tell you the clinical results are much better if you use these disc prostheses, and they state that disc prosthesis is superior over ACDF. And I don't know if we have to literature look that this holds true, and that's the idea of that talk, to give you an overview about the current literature. So the first question is, do prostheses are able to preserve mobility? And this is on the right-hand side, you see some pictures of a disc prosthesis was implanted in 2010, and 4 years after the surgery, there was there was no seen complication on the image, and this disc prosthesis is quite mobile. If you have a look to systematic reviews over 2,400 patients with a 1 and 2 years follow-up, they state quite clearly that this prosthesis preserves the segmental mobility. If you have a look to more recent publications, 1,557 patients from REN from 2014, 4 to 6 years follow-up. If you compare CDA with the ACDF, you see that the CDA is able to retain around 8 to 10 degrees of mobility versus ACDF with 0 degrees of mobility. But this is no surprise that we have that. But they also stated that we have a little bit of problem with these bridging heterotrophic ossifications. And in that study, they found an incidence of 3 to 17% of patients that have these heterotrophic ossifications. And if you have a closer look to these heterotrophic ossifications, you can use the McAfee classification, or this is an adapted McAfee classification from Christoph Mehren, a German spine surgeon. And of course, if you have a look to this classification, they state the grading of these ossifications. And for me, it's quite important. You have 2 groups. You have the groups with grade 1 and grade 2. These patients still have a good mobility in the segment, and grade 3 and grade 4, the mobility in these segments is already hugely reduced. And having a look at this study from Lyon and from 2005 and some other statements, that you will find a prevalence of these heterotrophic ossifications after CDA from 17 up to 90%. I think this is a huge number. And the systematic review from Dowell in 2020, they state that they found in 80% of these patients heterotrophic ossifications, but most of them are graded in 1 and 2 grades. So this is the ossification which does not affect the mobility of the patients quite great. And there were 1/4 of the patients, they have these grade 3 and grade 4 grading of the ossifications. But however, they find out it does, independent from the grade of ossification or the heterotrophic ossification, there was no clinical, no influence on the clinical outcome. So if the patient has a fused disc, most of the patients, they're doing quite well. So the industry tried to overcome this problem, and they changed a little bit the design of these prostheses. And this is a study from Mehren published in 2019, and he showed us that if you compare the old design of these products versus the new design, so heel versus no keel prosthesis will reduce the rate of heterotopic ossifications over the time, and this is showing in these bars. You see here for the old keel design, grade 3 and grade 4 ossifications after 24 months were reduced about 50%. And even changing the design of the prosthesis keeps the mobility much better. So this is the graph for the newer design, so without the keel. And this prosthesis was able to retain more mobility 2 years after the primary implantation in comparison to the keel design. So the design of this prosthesis might have an influence. According to the problem of the adjacent segment degeneration from the current literature reviews, we know that there are 2,632 patients from XU in the meta-analysis, that if you compare ACDF and CDR, you have 20% adjacent segment degeneration in the CDR group. So there is still a problem with adjacent segment degeneration, even if you use this prosthesis, versus a little bit more for this ACDF group, if you have 4 to 8 years follow-up. And if you have a look to the other meta-analysis from Badawi published in 2020, he was clearly able to show that 2 years after the index surgery, the adjacent segment degeneration was quite equal between these two groups, but for a longer time, so even after 7 years, the rate of adjacent segment problems in the ACDF group is getting a little bit higher in comparison to the prosthesis group, with 4% in the CDR group and 10% in the ACDF group. The question is always if the comparison between both groups is quite fair, because we compare a fusion group with sometimes oversized plates, or even the fusion group with only bone inside versus the disc prosthesis. And I wonder if it would be more fair to have newer studies comparing these intradiscal standalone in cages with integrated fixation versus the prosthesis groups. So that would be a fair review. Having a look to the clinical results, this is the newest meta-analysis. I found 6 studies, around 900 patients, 10 years follow-up. And they stated finally that there was a significant better VAS and neck pain disability index scores if you use the disc prosthesis. But the problem is, this difference does not meet the minimal important clinical difference. So it's a little bit better, but the difference is not that relevant. If you have using these CDR groups, you have a significant fewer secondary surgeries and adverse events, and there was no difference in neurological success if you compare CDA and ACDF. However, you have to read all these studies carefully, and I found an interesting review. They reviewed 74 studies, and there were 22 RCTs inside with 8 different prostheses with a 24 months follow-up, and they analyzed these papers according to a potential conflict of interest. And they found out that around 50 of these 74 primary studies had a potential conflict of interest, and if you compare the results out of these papers and have a look to the papers with a conflict of interest, if you have these left column, the papers with conflict of interest had over-reported the adjacent segment degeneration for ACDF. They had a low rate of heterotrophic ossifications, and they stated TDR is superior to ACDF. And the papers without conflict of interest, there were only 24 of these groups. They have a similar rate of adjacent segment degeneration comparing ACDF and disc prosthesis. They have a higher rate of heterotrophic ossifications after disc prosthesis, and they stated that TDR is non-inferior versus the ACDF. So having a look to the literature, I think it's clearly stated that the segmental mobility, the prostheses are able to maintain the segmental mobility. Regarding the adjacent segment degeneration, it's not that clear in the moment, but I think the CDA is a little bit in favor, and the clinical outcome is still questionable. There are hints that it might be better using disc prosthesis, but I think the proof that the disc prosthesis is much better than ACF is not yet done. So for me, superiority of cervical CDA is not yet fully proven in the moment. So for me, that's why my indications to use this disc prosthesis, this is a single and double level patient. The patient has to be below 60 years and they have to be healthy. I have a symptomatic cervical disc disease in the range of C3 to C7, and the patient should have radicular arm pain and or functional neurologic deficit. And you have to find a good reason for these clinical problems, like herniated nucleus pulposus, spondylosis with the presence of some light osteophytes and a little bit loss of disc height. We have to confirm that the facet joints are healthy, and the patient should have a failed conservative treatment, of course. Contraindications, we heard about that in the morning, is osteoporosis, the marked cervical instability, the severe spondylosis. I'm not a fan of using these disc prostheses if you have these huge bridging osteophytes, because the nature tries to fuse the segment, and I try to get it mobile. I don't know if that will work quite fine. If the disc height loss is more than 50%, the absence of motion in the dynamic X-rays, and of course the severe facet arthrosis and predominant neck pain in these kind of patients, I would not use the disc prosthesis. And I would not go for disc prosthesis if I bring in the smallest trial and I see a huge over-distraction of my facet joint, then I would convert from prosthesis to ACDF. So this is a typical patient, 36 years old female. She had a ACDF 3 years ago, and she came with predominantly left-sided arm pain, some neck pain, and the arm pain was radiating in the dermatomes C6 and C7. The neck pain was quite moderate, and she had some stenosis in the lower level and left-sided neuroforaminal stenosis. So this is a patient I will think about going for disc prosthesis, and that's what I have done. And interestingly, using these disc prosthesis, the curvature of the cervical spine changed a lot. So just now, the adjacent the lordosis of the disc prosthesis is already restored, and this patient is 1 year after the surgery with no arm pain and a slight amount of neck pain, but she can tolerate quite well. Question is always what will happen with these upper segment due to in the time of the surgery. She had no problems with that segment. That was only a soft disc stenosis, and I did nothing in that level so far. So take-home message. Out of the literature, I think disc prosthesis, they are able to preserve the segmental mobility in some prosthesis temporarily. We have this problem of phytotopic ossifications that might be changing with the more modern and newer prosthesis design. We have confirmed that we have a lower rate of adjacent segment degeneration and a lower rate of adjacent segment degeneration related to secondary surgeries. We have a somehow better clinical outcome, but the problem is just now from the studies we have, it will not meet the minimal important clinical difference. And I have always a little bit the problem that if you have a deeper look into these studies and know what kind of index group and what kind of prosthesis group was compared, I think the comparison of a bone graft in the disc space or an ACDF and with an oversized plate in comparison to a disc prosthesis is not a fair comparison. So for me, in the moment, respecting the contraindication of the use of TDR, I think the use of TDR so far is justified according to the actual literature status. But in the moment, we can't state that we should abandon ACDF because the prosthesis is superior. This is not proven by the literature so far. So you can still use both and respect the contraindication. Thanks a lot.